it is very important that you understand what CMS says about goal. And y'all, all of this documentation is coming from CMS Chapter 15, Outpatient Therapy Services. It's the 220 and the 230 rule. CMS says that all treatment goals must be designed to address each area identified in the evaluation. So what that means is this: if you did not identify it as a problem in the assessment, you cannot have a goal for it. Everybody get that? If you did not identify the problem in the assessment, you cannot have a goal for it. Now, when you start your treatment and you identify it later, you can document it in the evidence of skills service box and add a goal. We're still continuing from the original, from where we stopped last time. So let me tell y'all what page that is on. Okay, it's on page 35. Okay, so there are two types of goals, short-term and long-term. The short-term goals are simply incremental steps towards obtaining the long-term goal. They must relate to a functional deficit identified during the or during treatment. And if you document it, if it was from when you evaluated, but later on in treatment it became a problem, you are to document your findings in the skills service rendered box. And then you can add a goal for it. Okay? Your long-term goals is just the expected outcome of where you want the patient to be at discharge, and like we stated earlier, it should look like the patient's prior level of function. Wherever they was functioning prior level, that's what your long-term goals should look like. It's where the patient will be at discharge. So there are three main components of goals. And you guys, you don't need Kasamba drop-down boxes to tell you how to write a goal. All right? Y'all get too carried away with these drop-down boxes, and I read a short-term goal and it doesn't make a sense. It doesn't even flow. I don't even know what you're working on. I really don't know what you're trying to do. I think you're just selecting stuff in the boxes just because the boxes are there. But you do not need Kasamba to dictate to you on how to write a goal. You are to use those boxes when it is appropriate. It is not always appropriate. So you need to know the components. My goal needs to be patient, caregiver, oriented, measurable, with functional outcomes. So I don't need a drop-down box for me to write my short-term goal for ambulation. Patient will ambulate 50 feet with a rolling walker, with contact guard assistance to ambulate from their room to the dining room. That goal was patient-oriented, it was measurable, and it has functional outcomes. You don't need the drop-down boxes to tell you that. And your goals may include strategies or conditions. For example, compensatory techniques. Patient will alternate sips and bites with 80% accuracy to decrease oral residue or stasis in the oral cavity during the oral phase of a swallow. I don't need a drop-down box to tell me how to write that because I know what I want to measure. And my goals just need to have those three components, and it may include strategies. So remember, measurable means specific percentages, level of assistance, changing dependence on adaptive devices, degrees, standardized scales, or occurrence-based, 5 out of 10 trials. Do not use percentage ranges. The percentage ranges are in the drop-down boxes. You should never use percentage ranges because if the range says 75 to 90, when the patient gets to 75, that goal has been met. So, speech therapy, because you see it a lot with speech therapy. Your goals, your measurement has to be precise. So it has to say a precise percentage, not 75 to 90. If you use Kasama drop-down boxes, make sure you go back and you take the percentage range out, and it has to be precise, or it's 5 out of 10 trials. Mild, moderate is not a measurement for speech-language pathology. You can't say with moderate or mild, because what is that? How do I know when I get to mild? You don't. So for speech, that's not acceptable. Okay, So functional outcomes, we know what functional outcomes are. It basically quantifies why the conditions require treatment. Everything you do for a patient must have a functional outcome. It must relate to something functional. So here's an example. The word ADL is not functional. The ADL task that is being performed must be named in the goal, i.e. bathing, rooming, dressing, and toileting. You need to specify the type of ADL task being performed. Conditions, and we talked about this, there may be adaptive equipment or compensatory strategies that may be warranted, and I would suggest that you write compensatory strategies in the short-term goal, or you write adaptive equipment. Don't name it yet because you don't know what's going to be appropriate. So once you determine during your treatment what strategies will be appropriate, then you're going to talk about those. But don't write the specific strategy because you don't know. There's a lot of different strategies. So just say compensatory strategies, but you're going to go into detail about those strategies in your evidence and skill service box. So here's some examples of short-term goals. The resident will require, and you know there are 3 components. They are, what are they? We'll say it again. Measurable, with functional outcomes, and it must be patient or caregiver specific. So either the patient will or the caregiver will. And you may include some strategies. So here we go. Resident will require men assist to safely roll from side to side to maintain good skin integrity. The components, the resident measure is men assist. The functional outcome is to maintain good skin integrity. OT, resident will actively participate in 25 minutes of functional activities before requiring a rest break to increase endurance and strength for increased independence and safety with dressing tasks. The components, resident, the measure is 25 minutes. The functional outcome is to increase strength and endurance for increased independence with safety during dressing tasks. Resident will demonstrate ability to swallow a half a teaspoon of mechanical soft diet using compensatory strategy with 90% accuracy to maintain adequate nutrition. The components of this goal is resident. The measure is a half teaspoon and 90% accuracy. The functional outcome is to maintain adequate nutrition.
Let me ask you something.
Yes.
On that, I mean, how really would you be able to determine if it's 90%? If you could do 9 of 10 trials?
Well, that's why it was speech. You could do 9 of 10 trials is 90. So you measure it, you can do it in occurrence based. You can say 9 out of 10 trials, and 9 out of 10 trials would be 90% accuracy. So speech should always write in percentage of accuracy, or you have to do trials and then divide it. Okay, and just like if you were giving yes/no questions, you gave 10 questions, the patient got 5 out of 10 right, that's 50% accuracy. So, okay, the other one is resident will communicate or verbalize orientation to person, place, and time to increase communication competency with 100% accuracy. The components, resident, the measure is ×3 with 90% accuracy, and the functional outcome, why are they doing it? To increase communication competency. So remember, the long-term goal is basically where the patient will be functioning at discharge, and it should mimic your prior level of function. So for PT, the resident will achieve bilateral lower extremity strength within functional limits in order to improve energy conservation and safety. OT, the patient will be modified independent in toileting and upper-lower body dressing in order to return home alone safely. Speech, the patient will increase expressive receptive language skills with 90% accuracy to effectively communicate basic needs and wants to family and staff. Just some examples of some long-term goals. Okay, CMS also talks about in the 220.1 rule what you must do when you change the therapy plan. It says, while a physician may change the plan established by you, providing such services, you may not alter the plan established or certified by the physician without their written, verbal, or documentation. So what will be considered a change to your plan? When you change a long-term goal, that means if you, say for example, we're treating for expressive language, and we identify a swallowing problem, and we need to add a long-term goal for swallowing. That would be an alteration of the plan that will require you to reprint that plan and send it out for a doctor's signature saying that the plan has been modified. So, and when you do that, again, the rule is the physician must sign that within 30 days. Yeah, there's an error in this slide. Number 3 is not pertinent to that. You can change the frequency and duration, and you can modify short-term goals. Draw a line through the third one. That's a significant. Medicare says a change in the long-term goal, when you're adding a new goal, it requires a new physician signature. Did you draw a line through yours? See, you're not following instructions. Draw a line through it, because she's going to come back. Draw a line through number 3. Okay, it says, if a patient has achieved a goal and or has had no response to treatment that is part of the plan, the therapist may delete a specific intervention from the plan of care prior to the physician's approval. This shall be reported to the physician prior to the next certification. So whenever it is our job to keep the physician up to date on what these patients are doing. So just know any immediate alterations to the plan when the patient's making progress, you make sure that you keep the physician informed. Okay, and again, it must be signed within 30 days. Let's talk about the daily treatment note. This is, again, the part of the 220 rule, page 173. It says that Medicare requires that a daily note be documented, and that you should also document skills service provided since the last progress note. Your daily treatment note should give the details of the specific activities performed for each CPT code. So for Mid-South Rehab, when you enter a charge into the system, you have to note and write the activities that you perform in order to bill for that charge. Okay, and this is how you would do that. You would simply go to the TX daily note. When you enter your charge, click on the note, and you would simply list the activities that you did for that particular day. The progress report, and this is the 220.3 rule. The progress report provides justification for medical necessity. It is really important that you understand that Medicare says that the progress shall be written. The progress report shall be written by a clinician. Now, who's a clinician? Because you got to know what the exactly, the registered therapist. Or by the therapist who provided the service and supervises an assistant. The timing, CMS says that progress notes are due once every 10th treatment or once during each 30 calendar days. So this is CMS rules. Make sure you follow your company policy. And I think, am I correct, it's the same as CMS's. Every 10 treatments or at least once every 30 calendar days. Absences, CMS says they understand that holidays, sick days, and other patient absences may fall within the progress report period. If the patient is absent unexpectedly at the end of the reporting period, when the clinician has not yet provided the required active participation during that reporting period, a progress report is still required. Everybody got that?
Could you repeat that one more time?
Basically, your progress note is due at the time that it is due, whether the patient is sick, it's a holiday, or whatever. Even if the patient was absent and you didn't provide treatment the last 2 days or the last day, you still have to write the progress note. You can always do a progress note early, but you should not be late ever. Everybody got that? Because it's a holiday. Do I still have to write the note? Well, I didn't treat the patient today, but didn't you see him 9 other times? So you still should be able to write that progress report.
Well, the other thing too is if you're going on vacation and you've got several PRNs coming the next week, don't wait.
Yeah, y'all, exactly. Y'all ought to be ashamed of yourselves. When y'all go on vacation and you have delivered 8 treatments and somebody's going to come and cover for you while you on PTO, and they only have 2 more treatments left, and you're going to leave them stuck with writing the progress note, I would never come work for you again. You all should write your progress notes, because PRNs, especially if they're not your regular PRNs, you don't really want them writing your progress notes, because they're not going to know what to write, basically, unless you've left a detailed summary of those other 8 treatments that you've done. So go on and write your progress notes and get them all out of the way. The only thing is this: you cannot write a progress note and update a plan of care on the same day. So remember that when you're going on vacation. You cannot do both of those things on the same day, because someone's not going to let you. So kind of say, okay, I need to write my progress note today, and then on Monday update my 701. Okay, and like we said, we can write them early, but they should never be late, and that's in the CMS regs. CMS goes on to say that elements of the progress report may be written in the treatment note if the provider or clinician prefers. With this company, elements of the progress report is never written in the treatment note, so this is not applicable. So we can just skip that. But they also say that verification of the clinician's required participation in treatment during the progress reporting period shall be documented by the clinician's signature on the treatment note or the progress report. So during a progress reporting period, the clinician must have rendered of treatment to the resident. Now, when you do your supervisory visits according to your state practice acts, hopefully you all are participating in treatment, billing at least 1 billable service for 1 unit. That's the minimal requirement, and then documenting that it was done. Okay, a discharge summary. A separate discharge note written by a therapist is not required. However, Mid-South policy is that a discharge summary is. So for this company, you are required to write a discharge summary. Now, when you write a discharge summary, when a patient DCs to the hospital or they have whatever, you should write a complete discharge summary, and you should summarize where the patient was at start of care and where they are at end of care. So it should read start of care, max assist for bed mobility, end of care, min assist. Start of care for transfers, max assist, end of care, modified independence. It should read like that. Patient is now able to, and you list what overall how they're able to function. That should always be in your discharge summary. Sometimes we look at discharge, some patient DC due to hospitalization. Still don't know where the patient's functioning. If you do that, when the patient comes back, all you would have to do is go to that discharge summary and say, this is where he was when he left. Now let me go see if he's still there. Because if that has changed, or if he has not maintained that, you need to pick him up. So if you write a good discharge summary, I can't get to the patient's chart. Well, you don't need the patient's chart. You have Cassandra. If you did what you were supposed to do and documented a great summary, all you have to do is go back to that resident's name, click on that last discharge summary, read where he was when he left, and go and screen him. That's it. Quick and easy. Should be a second. Okay, and there we go. Discharge summary should include the patient's functional status at start of care and end of care. You should document the patient's current level of function at time of discharge. Okay, Medicare also says that assistants may participate in the progress report. It says reports written by assistants are not complete. The clinician must write a progress report during each progress report period. I know you all have assistant's progress report and the therapist progress report. It says this is what assistants can document. The assistants can document the objective measures. Those are the short-term goals, when the current versus the previous versus the target. Assistants may not make clinical judgments about why the progress was or was not made, but may report the progress objectively. For example, increase in strength is not an objective, but patient at 15 feet with max assist is. Okay, the clinician, this is the part of the progress report that CMS says that the clinician, the registered therapist, must document. The registered therapist must document any assessment of improvement, extent of progress, or lack thereof towards a goal. This is important because when you write the progress note before you move to the body, you need to compare the current measure to the previous measure for an improvement. If last week they were modest and this week they were modest, that is no progress. You, the registered therapist, have to document why no progress was made and what the plans are, what you're going to do about it. Same thing if they were modest this week and they have regressed, that's a regression. You still have to document why that happened. And you have to look at every goal and every goal stand alone. We get denials for claims that Medicare would say, patient has reached a plateau. And even if they plateaued in one goal and you didn't document why, that's what they're going to say, and they're not going to pay it. Because they have rules in here that, and we're going to get to that. Also, your registered therapist is responsible for a plan for continuing treatment, additional evaluation, changes to long and short-term goal, discharge, and an updated plan of care. And we already talked about the treatment notes. All right, so remember, you go into Kasamba to write your weekly progress report. When you get ready to report on the current week's goal, you keep the wording the exact same as your target goal. You only change the verb, tense, and the measure only. Once the target goal is written, it's written. You cannot make changes. You can't change the words. You can't add stuff in. Think of when a registered therapist writes the target goal, think of that as being a physician orders, that it must be performed this way. The only way that you can alter the goal is when they upgrade, downgrade, or modify it. Otherwise, you have to keep the wording the exact same. So it should not take you but a split second to write the current week's goal, because all you're doing is rewriting the target goal, keeping the wording the same. You change two things, and what are they? The verb tense and the measure. That's it. That's all you change. Okay, then after you do that, before you move to the body of your progress note, you want to compare the current measure to the previous measure to determine if the patient is making progress or if they've reached a plateau. This is important. This is straight out of the CMS regulations. And the beautiful thing about CMS, they don't keep secrets. They give you everything you need to get your claim paid. CMS says in the 220.3 rule that documentation should establish through objective measures that the patient is making progress. So the only purpose of that top box is to see if the patient is making progress. They just want to see measures. That's why you only change the verb tense and the measurement. That's all that top box is for. They go on to say, we know that a regression and plateau can happen during treatment. CMS says we understand that. And we're gonna recognize the fact that a regression or a plateau can happen. But if you continue to treat, the reason for the lack of progress must be noted, and justification for continuation must be documented if you continue to treat. What that means, you have to look at each goal. If there has not been a change in the progress, or if there has been a regression, CMS tells you what you got to do. You can't just ignore that. You're going to say, patient made excellent progress this week in gait and balance. However, no progress was made in strength. But there was subtle progress made, as evident in last week, patient was lifting a 2-pound weight, and this week they're able to lift a 2.5-pound weight. It didn't change the actual measure for strength, but the patient made some subtle progress. Or the patient did not make progress, next week you're going to vary the activities. Or patient did not make progress because he was ill for a couple of days or whatever. You have to tell them why, but progress is expected. So you can't just leave it, because if they audit the claim, they're going to say, and they're going to go all to the very first week where no progress was made, and they're going to take back all that money. So if you did that for 4 consecutive weeks, they're going to go back to the first time they were at mild assist. And a lot of times we don't know that it's a plateau until when they audit the claim. I don't know why this thing is fading out. When they audit the claim, they're going to go all the way back to the first measure when he became mild assist. It's weird, but that's what they do. And they can do that. That's important. Okay, so if not progressing, like I said, documenting the updates to treatment approaches, why progress was not made, any subtle changes in progress that did not change the measure, and your plans to adjust or downgrade the goals. Now, anytime you adjust, upgrade, modify, increase the complexities of a goal, you always have to document why you did it in the body of your progress note. You can say patient is making excellent progress in gait and balance, target short-term goals have been upgraded. Or a patient did not make progress in strength, goal has been downgraded. But you always have to document when a patient made excellent progress, goal met. If you select goal met, the goal is going to disappear and you're never going to be able to work on it again. So don't select goal met unless you do not want to work on that goal again. But it's always upgrade or downgrade if you want to keep working on it. Okay. Yes.
I know it varies from patient to patient, but how long would you wait before a plateau? Like
It's right when you say, no.
days they don't make any progress?
No, it's when you write the note. When you write that progress note, if they were mild assist last week and they're still mild assist, that's a plateau.
Well, I understand that, but I'm saying, like, say if you're keeping them on, that you've got them on for 100 days, you might go a week and they don't do anything.
You should never do that because you're the clinician. You should be changing it up immediately. Wow. So
Every week you change.
maybe if it's Monday and you see Monday, same, Tuesday, he's still the same, Wednesday, he's still the same. Are you going to keep doing the same thing? As a clinician? No, you shouldn't.
As long as you document or qualify the need for a change and everything, you're okay.
It's always going to be a need for change if they plateau or regress, because you would.
Clear-cut period of time to wait sometimes. I know
You don't wait. If he was at mild assist at the last progress note and he's still at mild assist, and if you write your progress note every 10 treatments you've been treating 2 weeks and didn't know they didn't make any progress, you should know that already. So change it up. I mean, if you're working with the patient every day, you should know that, okay, he's been at the same pace for the last 5 treatment sessions. You know that.
What I'm saying, I guess, is sometimes you read back through the notes and you'll see that they may have progressed up to 100 feet walking, and then they kind of had a little decline and slide back, and they're kind of teetering for a while. And they come back up.
But CMS says you're the expert. You need to explain that.
Just explain it.
That's right. You need to explain it. You have to justify it. If you're going to continue to treat, CMS says you are the experts. I don't know about gait. I'm a speech pathologist. You're the expert. That's just like you take your car to have your car serviced, and my car's been putt-putting for the last 4 weeks. He said, well, what do you think is wrong with it? I have no idea. You're the mechanic. All I can tell you is I've been driving this car and it's been putt-putting, but you're the licensed mechanic. You tell me what's wrong with it. So you're the one that's been working with the patient. You make it's your clinical judgment. You have to figure out.
I understand that. What if, like, say your patient has a UTI and they're treating them with some different medications? What you're doing is they're not progressing during that time, or they're confused.
And that's why, and you document.
Go through it and you just document it and keep going.
Yes, and you have to tell Medicare that the patient has experienced a UTI and that you believe that the UTI has altered their progress, but however the patient is on medication, patient is expected to recover, and you expect progress to the patient to continue to make progress after the UTI has been resolved. That's what you say. But you use your good clinical judgment and you document. So basically, this is what we talked about earlier, but if you notice, all these goals have been upgraded, new goals have been added, but just make sure that you compare the previous measure to the current measure to make sure that the patient is still making progress. Let's go to skills service provided since last progress report. Y'all, this is very important. This is the piece of the progress note that we get paid for. Okay, y'all hear me? This is the piece of the progress report that Medicare pays us for. This is the skills, yes. Yes, you can add a short-term, yes, you can. You can add a short-term goal without a physician's signature. The only thing that requires a physician's signature is when you alter the long-term goal, or you add something that was totally opposite, like, for example, speech is working on expressive language or receptive language, and we want to add swallowing. That's a whole different area. So for us, we would have to modify that plan and resend it out for another signature. If you add a new modality, that requires you to obtain a new clarification order and write the order in its entirety. It does not require you to get another signature on the plan, because he's going to sign the clarification orders. You already have a signature. So you just need to rewrite. If you add a modality, you have to rewrite your clarification order, PT and OT. Doesn't apply to ST, because we don't. All we write is they're going to be getting speech treatment or dysphagia treatment. That's it, or rehab or something. But if you add a modality, you have to write a brand new clarification order, and you have to rewrite the clarification order in its entirety, because whatever order you write supersedes the old orders. Yes? If the modality stays the same, you don't have to. Now, remember, y'all, when your orders expire, they expire. Now, if your orders have expired, you can't continue to treat with expired orders, then you would need to rewrite your clarification orders to continue physical therapy treatment 5 times a week for 6 weeks, for neuromuscular re-ed, gait training, da-da-da-da-da. But even if you add a new modality, you need to rewrite the clarification order in its entirety. Whatever order you write, the most current order always supersedes the previous order. Everybody got that? Yes.
Like the patient goes to the hospital, you treatment part B, and then you're meeting goals, short-term goals, if they get sick, go in the hospital for a day or 2 or 3, and they come back. Do you reevaluate?
You would, okay, here's the deal with Part B. Most people, when a Part B patient goes to the hospital, if they have a secondary payer, the facility holds their bed, okay? So for Part B, in most facilities, you don't discharge immediately, because if they come back within 2 days, you can just, and what you're going to put on the days that they're out withhold, patient is in the hospital. By the 3rd day, if they're not back, we discharge, because if they've kept them for 3 consecutive days, they've had some significant decline, and you're going to need to reevaluate. You're going to have to do a whole new evaluation anyway. Think about it. When a patient goes to the hospital in 3 days, a patient can decline significantly. So you will want to reevaluate them. You're going to discharge and start all over again. Now, if it's like a day or 2, no. I mean, you will, when you do go see that patient when they come back, you're just going to say, withhold, patients in the hospital. Tomorrow, withhold, patients in the hospital. Today, patient returned last night at 12 o'clock. You're going to start treatment again. But when you go see that patient, you're not going to bill for an evaluation, but you're going to be assessing where they are to see if you need to revise those goals. And you're going to document all of your findings. Okay, now you all can bill for a re-evaluation. So you can bill for a re-evaluation, write it up in the note area in the evidence of skill service box or the skill service render box. You can write the evaluation, but it doesn't require a new plan of care. And you can, if you need to upgrade the goals or downgrade, you can do that. Okay? All right, so this is what you have to document. You guys, the skill service box. Oh, Lord. Deborah. Oh, we have it. Y'all have it in your packet here. Yes, question? Go ahead.
There's a question that if a patient goes out and they stay overnight, regardless of whether they're A or B, that we
Not, you have to ask your facility, for a Part A patient, you have to discharge. That's for Part A. If you're not in a Part A home, if they are holding the bed in their Part B, you can keep those patients for a couple of days and not discharge. But by the third day, if not, they're not back by the third day, you need to discharge. Part A, you got to discharge anyway. The first day they're out at midnight because it starts over again. Understand that? Bed in the head at midnight. If the bed in the head is, if the head is not in the bed, you got to discharge. Remember that. That's the golden rule for all Part A, any HMO-like resident. Part B, if they are holding the bed, you can keep them. If they don't have the money to hold the bed, you have to discharge. So the key for Part B is the patient on bed whole? If the answer is yes, you can keep the patient with hold, just write with hold, patient in the hospital. You can do whatever you want on now. I'm just kidding, girl. Follow the same rules for Part B. Okay, you got to follow the same rule. If they leave and go to the hospital by the third day, if they're not back, you're going to want to DC and reevaluate them when they come back. So kind of follow the same rules you would for Part B services. But for you right here, ma'am, Part A, Kim, if the head's not in the bed at midnight, you got to discharge. I know those days are over. That's right, you can't do that anymore. That's over. Okay, so this is what you got to document in the evidence of skilled service. This is really, really important. You must document the details of all the activities performed. Do y'all get that? You got to, if you're working on gait, you got to give me a snapshot of what you did for gait. The techniques, don't just say did compensatory strategies. I don't know what that is. You know, if I don't know, I'm speech CMS is not going to know. Okay? Document rest breaks and why. Document when a resident has pain. Y'all, state surveyors are looking at this and they're tagging buildings. If you documented that the patient was in pain but failed to notify nursing, that is an automatic tag for a nursing home. So if you document in your note that the patient was in pain, you better be documenting nursing notified, because that's what they're looking for, that the nurse was notified. Even if you're treating for pain, you got to document nursing was notified. They will get a tag for that, and you will be the cause of the tag. Okay? If you are doing modalities, and I know in some of the outpatient clinics, y'all do modalities, you should always document skin checks. If there are any adverse reactions to the skin, you need to stop and notify the appropriate personnel. You always document the body part, the program, where it's IFC or whatever, electrode placement, and describe the intensity. Speech therapy, how many people are vital? Okay, never document the word vital stem. You always document NMES was provided. You document electrode placement, skin checks before and after. Vital stem or NMES should never be a part of your goal either. That is a treatment approach. I have seen people write vital stem in their goals. It's not part of the goal. It's a treatment approach. Okay, so here's some examples. This is a physical therapy example. PT, and this is what your evidence of skills service boxes should look like. Now, it should match your goals. If you're working on gait, balance, strength, it should go in there for gait, something for balance, something for strength. Yes.
It's hard for speech at least to distinguish when you do a daily note. My daily notes seem like weekly notes, and I mean, all this stuff is in each weekly note.
But what did CMS say? Did CMS say your weekly notes is what they look for? Doesn't matter. CMS says the progress report. So you want to write a good daily note so that if you're absent, I can, if I have to treat and you got sick, I should be able to come behind you and write your progress report, one SLP to another one. Exactly. So, yeah. So here you go. PT engaged patient in standing activities, including reaching outside the base of support and weight shifting, forward balance, left, right as tolerated for increased standing tolerance and to improve dynamic standing balance. For gait, notice they're They're saying as they go along, okay, that's what I did for balance. Now for gait training, this is what I did. With the rolling walker to increase activity tolerance with cues for improvement of posture, for increased lung expansion, and to increase overall safety skills with functional mobility. That's what they did for gait and why they were doing it. For bilateral lower extremity therapeutic exercise. So this is how you would list it out that way. And if you start with the very first goal for gait training, for balance, for whatever, you're going to list them out. You will make sure that you have something for every short-term goal. Because if CMS read that progress report and see that I don't see anything for gait, they're going to take back money. Your ultra-high rug level will probably go down to a medium because they're going to say, we believe the bulk of your treatment was for gait training. And you have nothing documented about that. And there's just some more examples. OT, residents seen 5 times a week for therapeutic exercise and activity, and was to treat with the following interventions: minimal resistance, yellow TheraBand exercise, 3 times 20, consisting of shoulder flexion, extension, elbow flexion and extension, internal rotation requiring a rest break between each sets before completion, digiflex, and they go on and on and on and on. ST, I love this one. This is my favorite one. This is just one of the best evidence of skill service I have seen in a long time. Oral motor exercises with and without resistance to increase lingual elevation, lingual lateralization, labial seal, labial rounding, and buccal tone. NMES placement, 3B4A, with skin checks before, during, and after. Speech therapists engage patient in hyalolaryngeal excursion, bolus manipulation, and trigger swallow initiation, thermal stimulation with cold swab to left facial arches to help increase swallow initiation time. PO trials of puree diet during MNES. You notice they didn't say feeding. PO trials. Y'all got to understand, you write a progress note every 10 treatments. Your progress note should look like this. You should be documenting. If I see one sentence and that's 10 treatment sessions, are you kidding me? You think CMS is really going to pay for that? Absolutely not. So you all really